The following podcast is part of a certified educational activity. Access the entire activity and complete the post-test at peerview.com/MBT860. Downloadable slides and practice aids are also available. Thank you for listening to Peerview Podcasts. We greatly appreciate your support and would like to hear from you. Can we ask for a favor? Participate today in a short 1-minute survey at www.peerview.com/podcast survey to share how podcasts play a role in your medical education routine. Again, that's www.peerview.com/podcast survey to participate. And now, on to today's podcast.
Hello and welcome to Rewriting Patient Care in Mantle Cell Lymphoma, how innovative therapy is poised to challenge conventional treatment. I'm Dr. Ian Flynn from the Sarah Cannon Research Institute in Nashville. Today I'm joined by my colleagues Dr. Pritesh Jain from the MD Anderson Cancer Center in Houston and Dr. Karen Jacobson from the Dana-Farber Cancer Institute in Boston. Okay, well, we'll get going now. And firstly, just to point out, it was that long ago that we thought of mantle cell lymphoma as being basically one disorder. We now know that there are multiple different subtypes of mantle cell lymphoma, which often have very different outcomes. If you could compare those patients with blastoid mantle cell lymphoma to the indolent leukemic non-nodal mantle cell lymphoma, the outcomes are very different. However, except for a few exceptions, our recommendations are relatively similar across these groups today, and clearly, hopefully that will change in the future. But in the upfront, treatment recommendations still center on chemoimmunotherapy for mantle cell lymphoma, with or without autologous transplant. However, the novel agents that we're going to talk about today have started to make their way into the NCCN guidelines in the relapsed and refractory setting for those patients who have had extended response to chemotherapy and even those patients who have had a short response to chemotherapy. Today's agenda is here. We have three different brief talks that we're going to give. The first is about the incorporating single-agent BTK inhibitors in mantle cell lymphoma. Next, we're going to go on to innovative combinations based on BTK and BCL2 inhibitors. In the final segment, we're going to talk about CAR T-cell therapy. Well, I'm going to start off with a case. This is a 67-year-old man who presents with a 5-month history of swelling in the right axilla. His ECOG performance status was 0. He developed fevers, night sweats, and pain. On exam, he had palpable right axillary and bilateral inguinal nodes. On CT scans, there was extensive adenopathy above and below the diaphragm. The largest node was 4.3 by 5.5 centimeters. And the patient had a biopsy which was consistent with mantle cell lymphoma. This patient was initially treated with bendamustine and rituximab, and he did not receive any maintenance therapy. Now, 3 years later, at age 70, the patient has a recurrence of a large lymph node in the bilateral inguinal region and the neck that are quite uncomfortable. His LDH is elevated at 370. A PET CT shows disease in the chest and abdominal regions, with the maximum lymph node about just less than 3 centimeters and the SUVs of about 5. The patient is now on a daily baby aspirin for cardiac disease. So I guess if you had this patient, we like to think about, and especially as we go through the data here in the next few minutes, about how you would treat this patient. But imagine the patient had some other comorbidities. Perhaps the patient also had hypertension. Perhaps the biopsy of the lymphoma showed a p53 mutation. Or perhaps the patient was on a proton pump inhibitor for gastroesophageal reflux. Atrial fibrillation is a common issue with Ibrutinib and some of the other BTK inhibitors. And how would that affect your treatment choice? And finally, if the patient was neutropenic, would that also affect what we did? Well, I don't know that there's necessarily a correct answer for all these things. Unfortunately, many of the therapies have some of these adverse events. For instance, hypertension. We know if someone's been on Ibrutinib for a while, that they can develop hypertension. It looks like that most of the BTK inhibitors and the therapies that we're going to talk about today work in the p53 mutated patients as well. And so maybe that's not a differentiating effect. We do know that proton pump inhibitors decrease the acidity in the stomach and make at least acalabrutinib not absorb very well, so probably one I would probably stay away from that. Atrial fibrillation is an issue, and so I would probably, if I was going to pick a BTK inhibitor for this patient, which I would probably stay away from those that have a higher incidence. For instance, we know ibrutinib probably has one of the highest incidences of atrial fibrillation. And finally, neutropenia. Well, all these therapies can cause, all these BTK inhibitors can cause neutropenia, but it looks to me like Xanabrutinib has a little bit higher incidence of neutropenia than some of the others, and so maybe that'd be a reason not to use that one in this drug. So I don't know. Let's turn to the panel. Karen, do you have any? You have similar thoughts or any different thoughts about how you would manage these different comorbidities and adverse effects such as the p53 mutation?
Yeah, I think these are great sort of what ifs and really highlight some of the difficulty with giving BTK inhibitors to patients who have some of these comorbidities. But I agree with you that it's the most active class for relapsed and refractory mantle cell lymphoma. So you just have to be creative on how to sort of mitigate additional toxicities in these patients. So, we often try to switch patients with GERD from a proton pump inhibitor to another to another temporizing or palliative approach as opposed to maintaining the proton pump inhibitor. I agree with you in terms of atrial fibrillation, trying to avoid ibrutinib in that setting and using one of the drugs that has a lower risk of exacerbating atrial fibrillation. And I do agree with you that a p53 mutation, doesn't change what you would reach for next. And then finally, neutropenia is likely going to be driven by the mantle cell lymphoma. So, I'd be hopeful that by treating the mantle cell lymphoma that you make space in the bone marrow for the patient to make healthy neutrophils, and hopefully that will actually be something that gets better after you start treatment as opposed to worse.
Those are great points. How about, Pritesh, how about you? Anything else to add there?
Thank you, Dr. Flynn. Yeah, I totally agree with both of your comments because these comorbidities are kind of very common practical observation in patients with this age group. And of course, with prognostication, as you know, high-risk mantle cell lymphoma, identification of by doing the rebiopsy, identifying whether it's a blastoid or a pleomorphic, having a p53 mutation or with high allele burden, those are the clear high-risk factors where we would choose the BTK inhibitor. But again, the issue is what to choose, and you brought up very important point on atrial fibrillation, and even the patient, as I will present some of the data, that even if the patient has EKG abnormalities, those itself could predispose to cardiac arrhythmias after giving ibrutinib. So definitely we would avoid ibrutinib in this setting, and we'll choose other BTK inhibitors. And of course, if there is always a possibility of clinical trial option, and these appear to be a transplant ineligible candidate, so we would consider clinical trials first, which is suiting the condition, and then next is to use the BTK inhibitor as pointed out with atrial fibrillation, neutropenia and everything. So that's very...
Well, I think we've got a lot to talk about, so I'm going to move on. I'm hoping to leave a lot of time for discussion, so we're going to go through this data pretty quickly. I think many of you, everyone probably knows now that there are 3 different BTK inhibitors that are approved for mantle cell lymphoma. Ibrutinib was the first, acalabrutinib and Xanabrutinib. Second generation molecules. These drugs are all approved for patients with mantle cell lymphoma that have had at least one prior therapy. I'm going to walk through some of the data that led to the approval of these drugs. The first was ibrutinib. We have more experience with ibrutinib because it's been available longer. Ibrutinib was approved based on the 1104 trial. This was a phase 2 single-arm study for patients with 1 to 5 prior lines of therapy. They received ibrutinib at 560 milligrams daily. Of course, this is different than the dose that we use in CLL, and they were to remain on it as long as the therapy was helping the patient and they did not have unacceptable toxicity. Speaking of the adverse events, I think now it's very familiar adverse event profile of ibrutinib. It's been around a while. I think many of us have a lot of comfort with using this drug. There are several that come to forefront in terms of issues. One we've already talked about, atrial fibrillation. There was about 11% atrial fibrillation rate in this trial for mantle cell lymphoma. Some of the trials, the numbers vary based on the age of the patient. and a number of prior therapies. And of course, we also know that there's an issue with bruising and perhaps bleeding in patients. And so the grade 3 bleeding was 6%, grade 3 or higher bleeding was 6% in this setting. It's amazing to me, honestly, if you think back not that long ago, how far we've come in mantle cell lymphoma, and perhaps how far we still have to go. Clearly, ibrutinib provides durable remissions for patients here. The duration of remission was 17 months, and the overall response rate was 67%, with a minority of patients achieving complete remission. If we look in a larger pool of studies that have done with ibrutinib, combining this 1104 study with other studies in relapsed and refractory mantle cell lymphoma, there's a couple of important points. One, the median progression-free survival is a little over a year. And the other is probably not all that novel, but is important to point out, is that patients who have less prior therapy do better than those patients who have more prior therapy. So here we see showed graphically in the red is the patients who have had one prior therapy, and the median PFS was 25.4 months, whereas if patients who had more than one prior therapy, it drops down to 10.3 months. So a real significant difference, and of course that is also reflected in overall survival. I'm going to move on now to acalabrutinib. Acalabrutinib was also tested in a single-arm phase 2 trial, very similar in terms to what we saw with ibrutinib, 1 to 5 prior lines of therapy. Single-arm study, 100 milligrams twice a day until progressive disease or unacceptable adverse events. Here, the adverse event profile, we're not seeing any atrial fibrillation in this trial, and although there's some 2% of other cardiac toxicity or adverse events noted in this trial. There is one unique side effect with acalabrutinib that I think is not seen in the others. It's headache. In my experience, this is really very self-limiting. Usually resolves in 2 to 3 weeks. It's the kind of thing that patients most of the time not even sure they should mention. It's usually grade 1. Some people think it gets better with caffeine. This is the progression-free survival from that study, 19.5 months. The median overall survival had not been met. The overall response rate was 81%, and 40% of patients attaining a complete remission. I think, and then finally we're going to talk about Xanabrutinib. So Xanabrutinib was more recently approved. This is, again, in a single-arm phase 2 trial with patients with more than with one or more prior therapies. They could not have significant cardiovascular disease to be entered onto this study. The primary response rate primary endpoint was overall response, and patients were treated with 160 milligrams of Xanabrutinib twice a day. This shows the results of this trial as well as the phase 1/2 trial that was previously conducted in mantle cell lymphoma. And what you're seeing is overall response rate in this trial of 84%, very similar in the phase 1/2 trial. High complete remission rate, at least in the pivotal trial of 69%. So these results led to the FDA approval of Xanabrutinib. The median duration response was just short of 20 months. Here's the progression-free survival, and the progression-free survival is 19.2 months. I think there's the median follow-up was 19.2 months, whereas the median progression-free survival was 22 months. There is certainly the tendency to want to compare these trials one for one in terms of their efficacy. I think that's difficult to do, frankly. They were conducted in different time points with different entry criteria. But the good news is that we have 3 excellent BTK inhibitors for the treatment of mantle cell lymphoma. This is the adverse event profile for Xanabrutinib. Again, I mentioned earlier some of the neutropenia that's been seen. Infections, I think, are common across this patient group in general, as well as patients on BTK inhibitors. And 3 patients here experienced bleeding events, but there were no reports of atrial fibrillation. So I think, all in all, a pretty excellent adverse event profile. But there are differences, right? This is a pictorial display of the kinomes of these 3 BTK inhibitors. On the right, you're seeing basically the relative selectivity, and on the left is a numerical display of this, looking at different kinases. And of course, none of these therapies are 100% specific for BTK. They do hit other kinases, and that may explain some of the differences in adverse event profile that we're seeing with these drugs. Here are some of the off-target or alternative targets of ibrutinib, and it may explain some of the adverse events we're seeing, including the cardiac toxicity, some immune events, some of the bleeding events that are seen. But that kinome that I showed, the selectivity is really only one half of the equation, or one part of the equation. We have to factor in the pharmacokinetics as well as the dosing, right? So here's the PK of the different drugs. The time on target or time on off target kinases may really affect the adverse event profile. And so really the only way we're going to know that the differences is through clinical trials. There's not yet, and I doubt we'll see one in mantle cell lymphoma, a randomized trial comparing these drugs in mantle cell lymphoma. But we do have one trial in Waldenstrom's comparing ibrutinib to Xanabrutinib. There are other trials that will read out soon in CLL comparing these different BTK inhibitors. But the upshot of this to me is that the efficacy was really very similar. And I don't think anybody argues that these next generation molecules are less efficacious. But there was a striking difference in the number of patients who developed atrial fibrillation or flutter. In this case, 2% for Xanabrutinib and 15.3% for ibrutinib. Now, there was also a greater degree of neutropenia seen with Xanabrutinib compared to ibrutinib. So there are some differences that are now really starting to come out in some of the randomized trials, and I think we will look forward to more randomized trials to better understand the differences. And so this is just a summary. I think we've been through this already. There's differences in dosing. There may be a different adverse event profile. And we're really learning now how to sequence these therapies in mantle cell lymphoma. So with that, maybe we'll take a few minutes and talk about, take some questions from the audience. Here I have a couple, and it's really about, what's the best way to sequence? Is there any role for BTK inhibitor sequencing in mantle cell lymphoma? Maybe Pritesh, could you take on that question? Is there a role for BTK inhibitor sequencing in mantle cell lymphoma?
Yes, sir. So thank you, Dr. Flynn. This is a very excellent presentation and very practical aspects and overview. Yes, so currently we do not have any data which could present that the sequencing works out, but clearly we are I'm conducting one trial here where acalabrutinib is given for patients who are intolerant to ibrutinib or discontinued ibrutinib due to reasons other than progression. So currently among the three of these, there is no data which can show that patients who progressed on ibrutinib would respond to acalabrutinib or Xanabrutinib. But there is clearly a clinical experience that patients who are intolerant to ibrutinib and then switch to acalabrutinib or Xanabrutinib, they still continue to maintain response and able to tolerate. But sequencing for treatment part, of course, the data, we do not have good data as of now.
Perfect. And I would add that biologically, there's probably no reason that these ones that we three mentioned that you would think one would be better, that going from one to the next would really help. There are some new non-covalently bound BTK inhibitors that are being developed, most prominently the Loxo drug, Arcule's drugs, and for reasons that aren't clear, they do seem there is some activity that's being seen in patients that are relapsed or refractory to other mantle cell lymphoma. Not clear to me why that would be, because it doesn't really seem to. They were developed based on their problems with CYS4081 mutations, which really is a problem in CLL and not in mantle cell. So Karen, let me ask you. The audience asked us the next question. It's about a 69-year-old patient who has mantle cell lymphoma, and the patient received hyper-CVAD and then subsequent autologous transplant, and now 3.5 years later develops atrial fibrillation post-transplant, and the cardiologist states he can probably stop rivaroxaban. Is he a candidate for a BTK inhibitor, and if so, which one? And maybe you can talk about just the whole issue here about what happens if, could you have kept this patient on anticoagulation as well? I mean, what are your thoughts about that and the choice of BTK inhibitors?
Yeah, so this is a great question and a challenging case, and I think this speaks to what you were saying, Ian, about the fact that these studies were done at different times when we had sort of different comfort and familiarity with some of the side effects. Because I think now atrial fibrillation on its own is not a contraindication to starting a BTK inhibitor. Of course, if a patient starts a BTK inhibitor and develops atrial fibrillation that's difficult to control or very symptomatic, that's another story. But I would reach for either acalabrutinib or Xanabrutinib in this patient, just in hopes of not exacerbating their atrial fibrillation and causing it to become symptomatic or difficult to rate control. I also would not be adverse to continuing their anticoagulation with either of those drugs. Of course, we worry about the antiplatelet effect of BTK inhibitors, which seems to be greatest with ibrutinib and less so with acalabrutinib and Xanabrutinib. So another reason in a patient with atrial fibrillation to favor one of those two drugs.
That's great advice. I'm going to combine two questions here together from the audience. They're about COVID and do we do anything different? Are we moving to more oral therapies? And getting away from antibodies or multi-agent chemotherapy. And then the second was about delaying therapy because of COVID-19. I have to say, I haven't really changed what I do based on this. Most people with mantle cell lymphoma need therapy, relatively soon. There's a small minority of people that you can delay, but the vast majority of people are going to need therapy, relatively soon after diagnosis. And I haven't changed what I've done based on it. And of course, I'm very nervous about patients, receiving chemoimmunotherapy, but I haven't changed to an all oral regimen. But in the relapse setting, as we're just discussing here, it's a great opportunity for these BTK inhibitors because they are all oral, keeping the patient out of the clinic at home and not exposing them. So. Listen, I think we need to move on. So Pritesh is going to now talk about the new wave of potent therapy in mantle cell lymphoma, looking at combinations of BTK with BTK inhibitors and BCL2 inhibitors. So Pritesh?
Currently, we are in a very exciting times in mantle cell lymphoma. The treatment paradigm is continuing to shift towards chemo-free treatment combinations. And this is based on the exciting data which is presented in the previous presentation with Dr. Flynn on the efficacy of BTK inhibitors, which are orally available agents. So the patients also are coming towards a point that they would like to minimize or move away from chemotherapy, and that's our aim, and avoid the short-term as well as the long-term toxicities, especially the second cancers, which is seen in the chemoimmunotherapy or with chemotherapies. Again, the second aim is to attain durable MRD negative responses. Immunomodulatory effects of these agents are also promising, as we have seen in the long-term follow-up of these studies. And these are effective as well as durable response, provide durable response in frontline setting as well in all the ages. We have to choose wisely though, considering the side effect profile of these agents, and we have to choose the agent appropriate for the individual patient's clinical profile. Randomized studies currently are ongoing for comparison of BTK inhibitor with combination with rituximab versus chemotherapy to look at in transplant ineligible patients. There are newer agents which are coming up soon, and one of them is Loxo. Then there is a combination of acalabrutinib with venetoclax, the triplet combination. So there are various combination of these molecules along with the BCL2 antagonist which are coming in picture. And the biggest, the first paper, so in the these are two clinical scenarios. These are based on the age. So patient 1 is a young patient who is 56 years old patient with a newly diagnosed mantle cell lymphoma who prefers minimal chemotherapy. And now this patient is coming to us with a low Ki67, ECOG performance status of 1, intermediate risk category. And what do we do with these patients? So that is one patient. And there is another patient who is a 75-year-old gentleman who is a newly diagnosed mantle cell lymphoma, who is transplant ineligible and who doesn't want to receive chemotherapy. And he is low risk by MIPI with a good performance status with a prior history of controlled atrial fibrillation and Ki67 less than 50%. So there are two different scenarios, young patient and the old patient, and I will provide you the data in and show that how these combinations with the chemo-free treatments have improved the survival as well as improved the response rates without using the chemotherapy in the induction setting. So here you can see that this was the first study where combination of ibrutinib with venetoclax in the AIM study was studied in the 24 patients. One of them was previously untreated and 23 patients were relapsed refractory. You can see that combination of ibrutinib, the addition of venetoclax dose escalation started at week 16 in this and the response rate was measured by the combination, and serial MRD assessment was also performed. This study clearly was the first study showing the efficacy of this novel combination, and after a median follow-up of 37.5 months, the median duration of response and time to progression is not reached, and 16-week overall response rate was 71% with a CR rate of 62%. And of course, the MRD negative rate also was around 60% in measurable patients. Then you can also see that the T53 aberrant cohort, which is around 50% of these patients, there was a 50% CR rate with this combination. Of course, the prior lines of therapy were only 2, and these patients were not previously exposed to BTK inhibitors. But this combination clearly showed that even the relapse setting, in a limited number of patients though, clearly you can see there is a improvement in the response rate as well as outcome without those toxicities which we encounter with chemotherapy. Next is the window 1 study which Dr. Wang has conducted here in our center. This is a study which has two parts. Part A is chemo-free window with ibrutinib and rituximab, and this study included patients who are young, less than 65 years of age, who are previously untreated patients. So in this part 1, we used 12 courses of ibrutinib and rituximab, or earlier if the patient has achieved CR, and then go with less number of chemotherapy, only 4 cycles of RI per CVAD. And this aim of providing this was to minimize the number of cycles of chemotherapy, which generally is around 8 courses of rituximab hyper CVAD regimen at our center, and to minimize the use of the chemotherapy. In this study, 131 patients were evaluated and median age was 56. You can see that the distribution of the low, intermediate and high risk patients was similar. You can see that the patients were equally distributed between low, less than 30% Ki67 or more than 30% Ki67, and number of blastoid was less, 11%. The efficacy after a median follow-up of 40 months, you can see that 100% patients have responded, and the response rate was, the CR rate was also 88% using the part A alone. And if you combine with the chemotherapy consolidation and looked at the overall response, it is almost 100% with 98% response rate in the total number of patients. By flow cytometry, we were able to achieve that 74% patient had MRD negative response in the patients who had initial bone marrow involvement. So these results are excellent considering the number of cycles of chemotherapy given. Even in the high risk cohort, you can see that the response rate did maintain. So this is a clear example that in the frontline setting for young patient, this is a very important achievement, and this is already made into the NCCN guidelines. Here I am showing you the plots with the progression-free survival. You can see that the median PFS is not reached, and only in high-risk patients, when you divide them with high and low Ki67, these patients did have a higher risk of progression, and this was statistically significant, although more follow-up is required in this. But you can see that 25 patients who had progressed, 17 of these had more than 30% Ki67, and 7 of them had de novo blastoid mantle cell lymphoma. And median overall survival again has not reached, and only 6 patients have died, 1 patient on study and 5 patients off study. So clearly this is a very important advance compared to the historical data from the rituximab hyper CVAD in this large number of patients. In this study, we looked at the patient 2, which is the elderly patient, and is given transplant ineligible patient. We enrolled 50 patients who were treatment naive, and were transplant ineligible. And we have used ibrutinib with rituximab combination in this group of patients. The median age in this study was 71 years. You can see that majority of these patients were low risk. That means they were non-blastoid patients. We did not include those patients, but you can see with MIPI, 50% of these patients did have high risk MIPI. And these patients also had Ki67 always less than 50%, but 37 patients had had low Ki67. But mainly this is a low risk cohort. Here you can see that the response rate has been 90% and 62% CR after a median follow-up for around 43 months. And MRD negative response was 87% based on the flow cytometry results. And median progression-free survival and median overall survival is not reached. This is a very important advance because you can see that the PFS and OS is not reached, and also that the number of patients who have progressed in this cohort is only 4. And these patients have progressed, so out of 4 patients, 3 patients actually had transformed to blastoid or pleomorphic. 2 patients had high Ki67, more than 30%, but less than 50%, and one was a T53 mutant, and another patient had a FAT1 and SF3B1 mutation. 5 patients have died, 3 have died due to progression, and 2 because of unknown etiology, but all the deaths were off study. Important in this study, 27 patients came off study because of various reasons. Now here comes the question of the choosing the BTK inhibitor and the intolerance issues, which I will show in the next slide. But you can see that 27 patients came off study and 4 patients were due to progression, and other patients came out due to side effects or other miscellaneous reasons. So the safety experience in the frontline setting with young patients in this was quite good, that you can see that the grade 1 and grade 3 and 4 toxicities with the chemo-free combination was only less than 10%. And you can see that majority of these patients had low-grade toxicities, grade 1 and 2 toxicities with fatigue, myalgias, diarrhea. Atrial fibrillation was 3%. Only one patient had grade 3-4 atrial fibrillation. But when you compare that with the chemotherapy, with the less number, you can clearly see that the toxicities were higher, grade 3-4 toxicities with chemotherapy in part B. In this, in the elderly study with ibrutinib rituximab combination alone, you can see that strikingly the percentage of atrial fibrillation, grade 3-4 atrial fibrillation was 22%, and low-grade toxicities were 6 in 6 patients. And you can see that the bleeding and the petechial bleeding, these are present in grade 1 and 2 in 42% patient. But this percentage of atrial fibrillation or cardiac arrhythmias in 11 patients was quite important. And we then looked, so the study was started in 2014-2015 when the criteria for enrollment for cardiac screening was not that stringent. We used the patients, we enrolled the patient who had the baseline EKG abnormalities such as some preventricular, atrial breathing, atrial arrhythmias or first degree heart block. But then these are the patients who have developed these cardiac arrhythmias in subsequently after reviewing retrospectively. So based on this, you can see that there are major phase 3 clinical trials ongoing with the combination of BTK inhibitors with other agents or with the chemotherapy. The first one is the SHINE trial, where bendamustine rituximab is being compared with the combination of ibrutinib with BR in newly diagnosed patients. Then you have the acalabrutinib with BR in the other study, and then mangrove study, which is comparing randomized study of comparing Xanabrutinib rituximab compared to bendamustine rituximab. Then you have enrich study, which is also ongoing with the rituximab ibrutinib versus rituximab chemotherapy in elderly mantle cell lymphoma. So there is clearly a great advance with these combinations, and we are also doing a combination of acalabrutinib with venetoclax in relapse setting, and there are multiple other combinations which are coming up. So I believe that we are in a very interesting era of combination therapy, and this has clearly improved the survival and outcome of these patients. And using these BTK inhibitor with the BCL2 antagonist combination early on clearly provides a very important outcome, impressive outcomes with the 100% response rate. However, the choosing the BTK inhibitors, especially in elderly population with cardiac issues, that's a very important thing. So we are also now starting Ecalabrutinib with rituximab in frontline setting for elderly mantle cell lymphoma, and also various combinations with the newer BTK inhibitor. So I think those in the coming years we would see. I hope to see that we are using chemo-free therapies as a frontline setting, providing such excellent responses, and with the novel biologic rationale for these agents. So we are clearly we are clear in a very interesting area and made an important advance with this. And I'm really hopeful for improving the patient outcomes with this advance. Thank you.
Pritesh, thank you for that excellent discussion. I think we have a minute for a little bit of a discussion. Maybe we should talk about those two cases that you led off the discussion with. The first was this 56-year-old man with newly diagnosed mantle cell lymphoma who prefers minimal chemotherapy. I'm not exactly sure how I would treat that, because it really depends on what the person means by minimal chemotherapy. Certainly, giving them a chemo-free regimen of Abrutinib or one of the BTK inhibitors in combination with a CD20 makes sense. Although if they went on to, in that window trial, if they went on to the second part with fairly aggressive chemotherapy, I'm not sure that, to me, whether that's really in keeping with what the patient was asking for. But certainly excellent data and good results. Karen, what do you think?
Yeah, I mean, I think this was a great review of a sort of a risk-adapted strategy of a chemo-free lead-in, and then giving the patient, a younger, more fit patient, an opportunity to have fewer rounds of intensive chemotherapy, so a shorter course. And I think that the data looks great, and I think this also belies the changing landscape of therapy here, where not only are we moving towards chemo-free regimens, but we're also moving towards regimens which incorporate some of these targeted agents in combination with chemotherapy, which I think complicates what we do next for these patients, and we'll talk about that in my talk. But I think the Window 1 study, definitely seems to me like it offers what this patient wants with excellent outcomes.
Definitely excellent outcomes, and I look forward to some of the results of those trials that you listed there. That truly getting away from chemotherapy, comparing the results with chemo-free regimens. I mean, maybe that's the ultimate goal here, and certainly the 72-year-old patient that you mentioned to begin with the newly diagnosed mantle cell lymphoma, auto transplant ineligible, doesn't want to receive chemotherapy. To me, that's the ideal patient for a BTK inhibitor, probably in combination with CD20 antibody. Karen, are you like mine there?
Absolutely, and to be honest, I hadn't seen those progression-free survival curves, but there was very little drop-off over multiple years of follow-up. I thought that was phenomenal. It looks much better than the combination in the relapse refractory setting.
Yes, definitely. Maybe when we get after your talk, we can dive down more into what Pritesh was talking about with substituting different BTK inhibitors and what that might look like. Well, next up is Karen, who's going to talk about understanding the CAR T-cell option in mantle cell lymphoma.
Okay. Great, thank you. So I am going to start with a case so that really draws upon a lot of the points that Dr. Flynn and Dr. Jain have already made. But we have a patient with relapsed and refractory mantle cell lymphoma who had failed a BTK inhibitor. So he's 55 and was diagnosed with TP53 mutant blastoid mantle cell lymphoma with a high Ki67. At the time of diagnosis, the intention was to treat him with upfront chemoimmunotherapy and an autologous stem cell transplant with a combination regimen of bendamustine Rituxan and Rituxan and cytarabine. At each staging scan after both parts of that induction chemotherapy, he essentially had stable disease, and so did not move on to an autologous stem cell transplant, and instead was switched to acalabrutinib, which he was on for about 3 months, at which point a PET scan was done and is shown here on the right, demonstrating progressive disease. So I might just pause here and ask Dr. Flynn and Dr. Jane, what would you think about doing for a patient like this? Certainly about the highest risk mantle cell lymphoma patient we come across, I think.
So I think your patient really illustrates all the problems we have with blastoid variant mantle cell lymphoma, and so I'm very frustrated as to know what is the right thing to do from the starting out. And to date, we still use chemoimmunotherapy, but the results are poor, and so it makes you wonder whether you should be, shifting to these novel therapies up front. For instance, the combination of acalabrutinib and venetoclax. I haven't really done that so far, but outside of a trial. But I wonder about that. And now that you have this patient who has now had a BTK inhibitor and progressed on that after chemotherapy, BTK inhibitor, to me the next line of therapy is CAR T cells.
Great. And so that is ultimately what this patient went on to receive. Of course, CAR T cells, specifically brexacaptogene autoleucel, was FDA approved for patients with any relapse refractory mantle cell lymphoma, which I think is an incredibly forward-thinking move on the part of the FDA. Of course, on the Zuma 2 clinical trial, which we will review, patients had to have received chemoimmunotherapy and a BTK inhibitor, but that's not what the label for Brexacel is in mantle cell lymphoma. And I think it's because of the trials that both of you have talked about, thinking about certain high-risk patients or any patients whatsoever who may see a BTK inhibitor either alone or in combination in the front line, and especially some of these high-risk patients that we don't expect to be chemotherapy responsive. So, when we think about how to incorporate CAR T-cell therapy into the treatment landscape for mantle cell lymphoma, certainly patients who have relapsed after chemoimmunotherapy and a BTK inhibitor are eligible and should be referred to a CAR T-cell center at the earliest sign of losing response to a BTK inhibitor. And I would argue anyone with chemo-insensitive disease or high-risk disease should be referred early, even potentially before they get started on a BTK inhibitor, because moving these patients to CAR T-cell therapy as quickly as possible is really important. I think it's also important to continue the BTK inhibitor up until the next therapy or CAR T-cell therapy, because we know when we stop these drugs, the patient's disease can really explode, leading to rapid clinical decompensation. It's important to know who not to consider CAR T-cell therapy for, and so patients with active infections or inflammatory disorders may be at higher risk of complications, and those may be patients that we may not move forward with, although that should really be at the decision and the discretion of the treating center. Once they're referred to a specialized expert center, the patient, you can expect that the patient will have their CAR T cells collected and then have shared care with you during the period when the T cells are being manufactured, after which the patient will receive lymphodepletion chemotherapy prior to CAR T cell infusion, often in the outpatient setting. And then their CAR T cells are infused, depending on the center, usually in the inpatient setting, but could be in the outpatient setting, after which there is a close monitoring period to look for signs of cytokine release syndrome and neurologic toxicity, where therapeutics for incidence of high-grade CRS or neurotoxicity will include things like IL-6 antibodies or steroids. And then once the patient clears that toxicity window and we expect those toxicities to be at low risk for recurring, they go into longer-term follow-up, where they're obviously monitored for response and then relapse and recurrence, and that can be co-monitored between the local center and the CAR T-cell center. So just to remind everybody about just sort of the logistics of CAR T-cell therapy, once we identify a patient, we do have to collect the T-cells through leukapheresis. Usually it takes about 1 day to collect those cells, and then they're sent to a lab where they get genetically modified to express the CAR on their surface. And after some quality control testing, they are then returned back to the treating center where they're given to the patient after a 3-day course of lymphodepleting chemotherapy. And that process of manufacturing can take anywhere from 15 to 30 days, depending on the product. When we're talking about Brexucell, which is the FDA-approved product here, it takes about 16 days to return back to the treating center. When we think about CAR T cells in non-Hodgkin lymphoma in general, before the studies looking at CAR T cells in mantle cell lymphoma, we know that anti-CD19 CAR T cells lead to durable remissions in patients with relapsed and refractory aggressive B-cell non-Hodgkin lymphoma. About 40% of people we think are probably cured after a single infusion of CD19-directed CAR T cells. And of course, what we'll spend the rest of the time talking about is the recent approval of Brexucell for relapsed refractory mantle cell lymphoma based on the results of the Zuma 2 trial. And I'll review some data from lisocabtagene maraleucel, another CD19 CAR that was in mantle cell lymphoma that was recently presented at ASH. So this is the schema for the Zuma 2 trial, which was an open-label phase 2 trial in patients who had relapsed refractory mantle cell lymphoma after chemoimmunotherapy and a BTK inhibitor. So 74 patients were treated on this study. They were allowed to have bridging therapy between leukapheresis and conditioning chemotherapy. And the primary endpoint was objective response rate. And so here are the results where the objective response rate was, as you can see, quite high. It was 92%, with 67% of patients achieving a complete response. And then what we did see at this recent ASH meeting was an updated duration of response, progression-free survival, and overall survival, now with a median follow-up of 17.5 months. And you can see in responding patients, somewhere between 50 and 60% of them are maintaining their response now out past a median follow-up of 17.5 months, which is significantly longer than we would expect these patients even to be alive, frankly, following failure of a BTK inhibitor. And similarly, you can see in the same excellent progression-free survival and overall survival curves. And you can see that the efficacy really pertained to patients in multiple different subgroups. Obviously, all of these patients had had a prior BTK inhibitor. Some of them were refractory to BTK inhibitors, and they did just as well. Others relapsed after having received a BTK inhibitor, and they did just as well. Patients who were intolerant of BTK inhibitors also did well on the Zuma 2 study. And then I'll just show some really hot off the press updated information from the Transcend NHL-001 study, which is the study of lisocabtagene maraleucel, another CD19 CAR T-cell therapy with a 4-1BB costimulatory domain. This is a study that included aggressive B-cell non-Hodgkin lymphomas and is currently being reviewed by the FDA for approval in that space. But it also included a cohort of patients with relapsed refractory mantle cell lymphoma, 32 patients to be exact. And you can see that the overall response rate of this product was 84% with a CR rate of 66%. And so a similar efficacy to what we're seeing with Brexucell. So now we'll go back to our patient who was treated on the Zuma 2 clinical trial with Brexucell. You can see their pretreatment scan that I had already showed you on the left, and then their 1-month post-treatment scan, which showed a complete response. And you can see now at 1 year and 2 years follow-up, he remains in complete response. So it's wonderful that there's such great efficacy, but what about safety in mantle cell lymphoma? So as we already alluded to, the major safety issues that we're worried about after CAR T-cell therapy are cytokine release syndrome and neurologic toxicity. Grade 3 or higher CRS and neurologic events occurred in 15 and 31% of patients respectively, and thankfully none were fatal. These are very similar rates of grade 3 or higher CRS and neurologic toxicity to what we see with axicabtagene isocaptogene siluleucel, the sort of sister product to Brexacel, in relapse and refractory aggressive B-cell non-Hodgkin lymphomas. When we look at lisocaptogene maraleucel in relapse and refractory mantle cell lymphoma, when we look at cytokine release syndrome, you can see actually only one patient had grade 3 or higher cytokine release syndrome, and only 4 patients had grade 3 or higher neurologic toxicity. So we see a similar sort of improvement in the toxicity profile with this 4-1BB CAR compared to the CD28 CAR, and that's the paradigm that translates over from what we see in relapse and refractory aggressive B-cell non-Hodgkin lymphoma as well. So when we go back to our case, again, just to remind you, this is the 55-year-old man who had chemotherapy refractory and BTK inhibitor refractory blastoid mantle cell. He was treated with anti-CD19 directed CAR T-cell therapy, and on day 3, he developed a fever consistent with grade 1 CRS, and 2 days later, that progressed to fever with fluid responsive hypotension, which constituted grade 2 CRS. So at that point, he was treated with tocilizumab as well as dexamethasone for just a single dose, with good resolution of his CRS and the intent of not having his CRS progress to higher grade or grade 3, which would be fluid unresponsive hypotension and a need for vasopressor support and a need for an intensive care unit stay. So thankfully that mitigation worked. And then 2 days after that, he developed grade 1 neurologic toxicity with some mild confusion and inattention and some expressive aphasia. At that point, we monitored him very closely with serial neurologic exams. He had a head CT, we did EEG monitoring, and there were no significant findings. And his mental status returned to baseline within 1 to 2 days later, after which he was discharged home. So that would have been grade 1 neurologic toxicity, which of course we monitor very closely, but we don't intervene upon. When patients start to develop grade 2 neurologic toxicity, which is the type of neurologic toxicity that leads to an inability to do independent activities of daily living, like operate a cell phone or things like that, or grade 3 neurologic toxicity, which is when patients actually lose their ability to do activities of daily living, then we probably would have intervened with steroids at that point, again, trying to avoid higher grade 3 or 4 neurologic toxicity, which potentially could land the patient for closer monitoring in an intensive care unit. So, this is certainly a big leap forward for therapies in mantle cell lymphoma, but it's not the end of the road. I think there's more to learn about where CAR T cells may land in mantle cell lymphoma. We've talked a lot about, going through these hoops of treating very high risk disease like blastoid or pleomorphic variant, TP53 mutated disease with high Ki67, with chemoimmunotherapy when we don't expect those patients to respond. And so we've already discussed today about moving some of the targeted agents earlier into the lines of therapy for these patients, but maybe CAR T cells could also be used earlier for these patients, especially if they could be paradigm changing and offer not just long-term disease control, but possible cure. And we'll need longer follow-up on these CAR T cell studies to understand that. I think there's also the group of patients who have frontline chemoimmunotherapy who are MRD positive after frontline chemoimmunotherapy, and whether CAR T cells could replace auto stem cell transplant in that space. And then finally, what about using some combination approaches and combining CAR T cells with other drugs like BTK inhibitors? We've already seen this being done in CLL, where combining Ibrutinib either before or during CAR T cell therapy seems to improve outcomes and potentially even attenuates toxicity. And that may be a paradigm we could translate to mantle cell lymphoma. And so I think the future is bright, and we need longer follow-up on these studies and future investigation to really understand how robust CAR T cell therapy can be for our patients. Thank you.
Great, thank you, Karen. That was a great talk, great overview of CAR T cells and how this is really changing how we treat patients with mantle cell lymphoma. There's a few questions here from the audience. I thought maybe we would work through some of them. Karen, to you, how early does it make sense to consider cell therapy in mantle cell lymphoma? You touched on this briefly. You mentioned that while it's after BTK inhibitors, well, the Zuma 2 was done after BTK inhibitors, that's not really what the indication is, and you could use it earlier. In your everyday practice, how are you incorporating CAR T cells in mantle cell?
So, I think it's a complicated question for, I think, two reasons. One is just because of the way the studies were done. Patients had chemoimmunotherapy and BTK inhibitors, and so and there is toxicity associated with these CAR T cells, and so it's right now it's hard to stray from doing it in the third line in those settings. The other thing is that we know that from the CLL data that patients who were pretreated with ibrutinib do better with their CAR T cells than if they had not been pretreated with ibrutinib ahead of time, and that may speak to sort of the fitness of the T cells that are collected to actually make the CAR T cell product. So, I do worry about taking patients before seeing a BTK inhibitor directly to CAR T cells, even for high-risk patients, like patients who are refractory to chemoimmunotherapy, because I worry that maybe the efficacy of CAR T cells may be diminished. But what I do think is, for this patient, this young man who had, that very, very high risk mantle cell lymphoma, I'd love to see some of the studies that Dr. Jane presented make it to the front line where we would use a more targeted approach in that setting, because this patient screams chemotherapy insensitivity. And then I think CAR T cells could be used in the second line for a patient like that, either when they lose their response or even have a partial response to targeted therapy. That might be the best place to use CAR T cells for a patient like that. But it's a moving target. And like I said, I think the FDA was actually very clairvoyant and very forward-thinking with their label so that we could figure out what the best frontline therapy is for all of these different groups that you identified at the beginning, Dr. Flynn, with mantle cell lymphoma and how to best manage them upon diagnosis.
Yeah, great, really great points. A lot of questions to answer, a lot of trials. We need more trials, I think. Yeah. Hey, Pritesh, let's talk about you did a great walkthrough of some of the combinations with BTK inhibitors in the frontline setting. So there's a question here about do you really? I mean, in select populations, you mentioned basically replacing chemoimmunotherapy, such as in the elderly population. But do you foresee that just completely getting rid of chemoimmunotherapy in the front line and going directly to a doublet or a triplet with venetoclax, maybe moving the venetoclax BTK inhibitor frontline with or without a CD20? Do you think that's where we're going?
Yes, thank you, Dr. Flynn. Absolutely. So this is a very important question, and I could provide an example that the study which we are currently doing, that is the Window 2 study, where we have ibrutinib, rituximab, and venetoclax triplet in the frontline setting. And for the low-risk patients, we do not give any chemotherapy subsequently. Only 2 cycles of chemotherapy is given for patients who are medium risk, and those patients who are high risk will get 4 cycles of chemotherapy. So clearly, it is shifting towards that in low risk patients, the triplet is highly effective, and the results we will present, but the data looks very good. Triplet can get away with the chemotherapy in low risk patients. So that's where it is coming to. And plus, the 2 weeks ago there was a study in blood in relapse setting where ibrutinib, rituximab, and venetoclax combination was reported from the European group. And there were very few patients who were previously untreated, like 8 or 10 patients, but still the results look quite interesting. So I believe that in next year or so, when we present the Window 2 study and the studies from Europe, the French group is doing acalabrutinib, venetoclax, and obinutuzumab study in the frontline setting. So those results would clearly provide us very good impetus that especially in low risk patients, we can get away with chemotherapy.
Yeah, I mean, in CLL, this is certainly the move, right, to get away from chemoimmunotherapy. We know that chemoimmunotherapy doesn't work in p53 mutated patients, and so going directly to combos with a BTK inhibitor or venetoclax really seemed to be the way forward in that disease, and clearly survival advantage. I can imagine you're mentioning the low risk patients, but I can also imagine in some of the high risk that this might work as well. As a transplanter, I'd say it'd be great to be able to get rid of transplant as well, and so hopefully these therapies would make some of that possible. So Karen, one of the obstacles I think with CAR T-cell therapies, at least in a lot of people's minds, is the adverse event profile. So you talked about how that the adverse event profile wasn't that different in mantle cell lymphoma than it is in large cell lymphoma, but it's still pretty significant. I mean, it's pretty scary when patients go through the neurotoxicity, the ICANS, and especially for family members seeing them go through it. How are we going to move that forward? Where do you see the advances in that field, and how are we going to make it easier for patients to get this therapy?
Yeah, that's a great question. I think we're already seeing sort of an improvement over time, certainly in rates of higher grade cytokine release syndrome. For instance, 3 years ago, we would not have treated this gentleman with tocilizumab and steroids when he had grade 2 CRS, and now we are. So we're seeing lower incidences of grade 3 CRS than even are reported on these clinical trials, because the readout for these clinical trials is always several years after the trial is conducted. The neurologic toxicity, especially with the CD28 CARs, has been a harder nut to crack. Generally we see about a third of patients have high grade neurologic toxicity, and thankfully in 99% plus, it's reversible and self-limited and gets better with time, but it is distressing and difficult for family members to witness, and also difficult for a patient to recover from. And I think that we need to understand the mechanism of the neurologic toxicity better. There are several clinical trials looking at prophylactic mechanisms or drugs to give to patients to try to combat some of the key cytokines that we think are implicated in the risk of developing neurologic toxicity, and those are being given at the time of CAR T-cell infusion or even ahead of it, so to try to decrease the risk of those toxicities, and so hopefully those will be effective. And then there are newer constructs and newer products that are in clinical development to try to mitigate these risks. So I think we will improve, but at least thankfully where we are right now, it generally is a reversible and time-limited toxicity, and we're getting much better at supporting people through that.
Well, we've had a great discussion. I want to thank the faculty for their participation today.
This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/MBT860. This activity is supported by educational grants from Beijing Limited, Pharmacyclics LLC, an AbbVie company, and Janssen Biotech Incorporated, administered by Janssen Scientific Affairs LLC.